Now, the other component of phase 4, concurrent with developing strength attributes, is athletic reconditioning, which is in essence conditioning specific to the metabolic or energetic demands of the athlete's sport. In most sports, the best performing athlete is one who can produce more work with less fatigue. For example, being able to run faster with less fatigue. Fatigue is the most critical limiter to performance in sports because it is, as I mentioned, a mechanism in which the muscle inhibits its own contraction in response to a high metabolic stress. So if we take two athletes, for example, athlete A experiences this fatigue at a running workload of 8 miles per hour, while athlete B does not at the same workload. This means that the metabolic stress in the active muscles of athlete A is much greater than athlete B at this 8 mile per hour workload. And thus, athlete A experiences fatigue and their muscles, quote unquote, pumps its own brakes to relieve it from this stress, while athlete B is able to sustain this 8 mile per hour workload because there is no fatigue. So what variable denotes this point in which fatigue mechanisms set in at a particular exercise workload? It is the anaerobic threshold. The anaerobic threshold is the point or workload at which the muscle experiences fatigue, and any greater workload will result in more fatigue and thus is less sustainable. So to reiterate, the anaerobic threshold is the point at which there is an insufficient rate of oxygen availability for the working muscle to satisfy its energy/ATP needs through aerobic metabolism. And thus the muscle requires an additional backup energy system called the anaerobic system to help meet the energy demands. To relate this to the example earlier, at 8 miles per hour, athlete A has exceeded the anaerobic threshold, and the aerobic system cannot fully meet the energy needs due to insufficient oxygen availability, and thus are using the anaerobic energy system to help meet the remaining energy demands that the aerobic system cannot fulfill. For athlete B, the 8 mile per hour workload is not fatiguing because there is sufficient oxygen availability for the aerobic system to fully satisfy the muscle's energy needs. So the anaerobic threshold for athlete A is lower than athlete B, and you could say that athlete A is less conditioned than athlete B. So as I said earlier, anaerobic threshold is one of the two components of aerobic power, the other being aerobic capacity, which is quantified by VO2 max or maximum oxygen consumption rate. Anaerobic threshold is quantified by two common variables that can be tested in the laboratory: lactate threshold and ventilatory threshold. Now, we won't spend time talking about these variables and how to measure them in this class, but this is a major topic for your advanced exercise physiology course, especially the lab component of that course. So as cardiovascular adaptations contribute to aerobic power through its impact on aerobic capacity, metabolic adaptations contribute to an improvement in aerobic power through its impact on anaerobic threshold. So what is metabolic adaptation within the current context of discussion? Metabolic adaptation is an adaptive response to the metabolic stress associated with exercise at around one's anaerobic threshold. So then what is this metabolic stress associated with the workload of one's anaerobic threshold? The metabolic stress that is associated with the anaerobic threshold and thus metabolic adaptations over time is muscle hypoxia. Hypoxia is defined as the oxygen availability for a given cell not matching the oxygen requirement of the cell. So in relation to exercise, as one increases the exercise workload towards the anaerobic threshold workload, the oxygen demand increases to support the increasing demand of energy from the aerobic energy system. At the anaerobic threshold workload, the oxygen demand has increased to the point at which the rate of oxygen availability cannot keep up with the demand. Thus, oxygen availability is lower than the oxygen demand, and thus there is hypoxia in the muscle. Hypoxia is a stressor to any cell in the body, including muscle cells. So the muscle cell will respond to relieve itself from this hypoxic stress. That mechanism is called fatigue, the muscle's own inhibition of muscle contraction to reduce the workload and thus the oxygen demand to a point where there is no more hypoxic stress. So what happens when you train at around your anaerobic threshold and expose your muscle to this hypoxic/metabolic stress repeatedly over time? What do we know about training adaptations? When a stressor is imposed on the muscle repeatedly over time, the muscle will adapt to that stressor. So what is one way that the muscle can adapt to lessen the hypoxic stress of the anaerobic threshold workload and eventually make that workload less fatiguing and more sustainable? One fundamental way is to boost the efficiency of the aerobic energy system, and that is largely afforded through an adaptation that increases mitochondrial biogenesis, or the formation of mitochondria. As we all should know by now, the mitochondria is the cell's main power plant and is where aerobic metabolism occurs. Mitochondrial biogenesis is not only an increase in mitochondrial number within the muscle cells, but it is also accompanied by an increase in its size and density, meaning the inner components of the mitochondria where aerobic metabolism occurs increases. As a result, the mitochondria's ATP producing quote-unquote power increases, thus improving one's anaerobic threshold workload, meaning the aerobic system is now able to satisfy the energy demands at higher workloads. And the previous anaerobic threshold workload is now less fatiguing because there is less muscle hypoxia at that prior anaerobic threshold workload. So in order to produce these effects, one must then train at around their anaerobic threshold. Otherwise, there will be insufficient stress to optimally elicit these metabolic adaptations like mitochondrial biogenesis. Now, the other two metabolic adaptations listed here, I will not cover in this class. This entire mechanism underlying aerobic adaptations and conditioning will be a major topic for your advanced exercise physiology course, so we will reserve all those details for that course. So during phase 4, the athlete is now engaged in a conditioning program that is at workloads around the anaerobic threshold. So this would include high intensity steady state exercise at workloads right beneath the anaerobic threshold, and exercise modes that are above the anaerobic threshold, which include high intensity interval training and sprint interval training. These modes are obviously intermittent because the intensity of the high intensity or sprint intervals is fatiguing since it is above the anaerobic threshold. Now finally, phase 4, which is the assessment to return to sport. Of course, the assessment prior to issuing a return to sport status to the athlete must be systematic and comprehensive to avoid high risk for re-injury. This is where controversies with potent analgesics are relevant, as it can give false positives to this series of assessments since pain or hesitation during movement is a major factor. So here we have an example breakdown of the assessments a clinician would perform towards the end of phase 4 as the athlete has recuperated strength and overall performance. Now this particular breakdown is specific to a unilateral hamstring strain situation. Now these assessments are as objective as possible, but there are also subjective elements as well. The more technology for quantitative assessment there are available, the more objective these assessments can be. But of course, not every clinician has access to these technologies. So first is the obvious. Does the athlete present with hyperalgesia or tenderness upon palpations? If yes, then the athlete must continue with their current phase of rehabilitation. If no, they can move on to the next assessment, which is strength testing. This can be ideally performed using an isokinetic dynamometer so that the clinician can assess force output at different velocities and objectively compare force output to baseline levels or the uninjured contralateral limb. Since an isokinetic dynamometer is not easily accessible, modified strength tests are more commonly utilized. For example, in the case of a hamstring rehab, a unilateral strength test on the squat and hinge exercise can be implemented. Now, what we are looking for is the difference in strength between the injured and uninjured muscle or limb. This is obviously pertinent to a unilateral injury scenario. If there is greater than 5% difference in strength, then the athlete continues to rehab with strength training emphasis. If the difference in strength is less than 6%, the athlete undergoes the next assessment, which in the case of the hamstring strain is the H test, which was established previously by Askling and colleagues. Now, during this test, the athlete lays in a supine position on a therapy table with legs straight. The upper torso and the uninjured limb is strapped down. The athlete is required to perform repeated and rapid hip flexions of the injured limb with the limb straight and up to full range of motion. This is called an apprehension test to assess how apprehensive or fearful the athlete is while performing this rapid movement. The level of apprehension is usually reported by the athlete on a visual analog scale of 0 through 100, with 100 being the most severe level of fear or apprehension, and thus insecurity while performing this test. So if the athlete is determined to be insecure or apprehensive, about 1 to 2 weeks of rehab is added. Otherwise, the athlete can move on to some other functional test, such as the single leg bridge test. This is essentially an isometric single leg glute bridge. This test allows the clinician to examine whether there is discrepancies in body positioning between the uninjured and injured limb after repeated repetitions. For example, if the hamstring is still weak and unstable, the hip on the injured side would typically dip and there will be difficulty in extending the hips on the injured side. If the athlete fails to perform more than 29 reps, then further strength training with stabilization focus would be implemented. Otherwise, the athlete is able to move forward into sport-specific movement testing, which is not a standardized test. This is more of a subjective test to see if the athlete is able to perform movements that are common in their sport without hesitation or pain. At this point, if the athlete is able to perform these sport-specific tasks without hesitation or pain, they are typically ready to return to sport. So now that we've covered all 5 phases of post-muscle strain management and care, I want to spend a little time discussing some new alternative therapy modalities that have gained a lot of recent attention amongst the sports medicine community as well as researchers. First, starting with blood flow restriction therapy, or BFR. So first, let's discuss the underlying concept behind BFR therapy. Here we have the figure I presented earlier on the underlying mechanisms of muscle hypertrophy. We discussed mainly the importance of mechanical stress in promoting muscle anabolism, or myofibrillar protein synthesis, and eventually muscle growth, or hypertrophy. Now, the other factor that contributes to muscle hypertrophy during training is the metabolic stress component. This is likely not the most critical component versus the two, but it is nevertheless a known stressor that induces hypertrophic adaptations in muscle. Now, the metabolic stress here is similar to what I described earlier when discussing conditioning. It is the stress associated with the anaerobic threshold and is largely characterized by a hypoxic environment within the muscle cell. Now, I didn't mention this earlier, however, this hypoxic stress is linked to acute muscle cell acidosis, which is caused by an accumulation of free protons, which are positively charged hydrogens. The acidosis is what directly links the hypoxia to fatigue, or specifically the inhibition of muscle contraction machinery. Now, this hypoxic/acidosis environment or stress within the cell, when imposed repeatedly, has been associated with the hypertrophic adaptations in muscle to training, alongside the mechanical stress. In normal resistance training situations, mechanical stress and metabolic stress are not mutually independent of one another, meaning they occur at the same time, and they have a direct relationship. This means that when mechanical stress increases, metabolic stress increases, and vice versa. Now, what is the issue when it comes to a muscle strain situation when trying to redevelop muscle back to pre-injury status? Well, one of the issues is that hypertrophy is slow because the athlete cannot place a lot of mechanical stress on the muscle due to its vulnerability to tension, and thus the metabolic stress is low as well. So the question is, can you isolate the metabolic stress somehow while minimizing the mechanical stress? Like I said, these two stressors are normally hand in hand, but is there a way to minimize the mechanical stress while maximizing the metabolic stress during resistance therapy or training? This is where the concept of BFR was born. BFR training was developed by Japanese researchers under the nomenclature of Katsu training, and is a method of restricting blood flow in and out of contracting muscles, utilizing a pneumatic cuff system around the limb, superficial from the active muscles. Now, BFR can only be performed for muscles of the limbs, so cuffs can go on the upper arm or leg near the armpit or the groin region, respectively. So what is the purpose of BFR training? One, to simulate that post-anaerobic threshold environment in active muscles with work that otherwise would not create this environment. So in essence, creating that hypoxic acidosis environment in the muscle using loads that would normally not create it. Two, to increase metabolic stress while minimizing mechanical stress, since the muscle is vulnerable to mechanical stress or tension during a post-strain situation. And finally, three, to achieve hypertrophic adaptations to resistance training using sub-maximal loads or lighter loads that would normally not be optimal for hypertrophy. Basically using the metabolic stressor to stimulate myofibrillar protein synthesis and thus growth without the mechanical stressor. Now, the pioneer BFR studies focused on applying BFR during walking exercise, which we know is normally not an exercise that is conducive to hypertrophy. But what they found, especially in older adults, was that walking with BFR over time produced growth in the lower body musculature. These outcomes had huge clinical implications for those with limited mobility, such as older adults with functional limitations, and of course those who are rehabbing from soft tissue injuries like a muscle strain. So how does BFR training work? How does it create this post-anaerobic threshold hypoxic and acidic environment in muscle cells? First, the cuff at a specified pressure, which we will discuss later on, restricts oxygenated blood flow to the muscle. So this would be arterial blood. It does not occlude arteries, but just restricts them, and thus the flow of oxygenated blood to the active muscles. What this does is reduce the rate of oxygen delivery and thus availability to those active muscles while it is contracting during exercise. This would immediately reduce the anaerobic threshold of those muscles and place those muscles under a hypoxic stress with even minimal activity. Thus, with light loads like 10 to 20% of 1RM, the metabolic stress on that muscle is significantly heightened without the mechanical stress, since a 10 to 20% 1RM load does not elicit high mechanical stress. So even with light loads, the hypoxic stress and thus acidosis is elevated to a level similar to what would be achieved with higher loads, like say 70 to 80% 1RM without BFR. BFR also restricts blood output from the active muscles. So here we are talking about the venous outflow of deoxygenated blood from the muscle. During BFR, the pressures applied by the cuff would only restrict arteries, but it would totally occlude veins. This would exacerbate the acidosis since the free protons are likely to accumulate since they cannot circulate out from the active muscles due to the occluded veins. This would not only result in more fatigue, but also pain. This is that burning sensation you often experience when lifting weights. The reason why there is a lot of pain with BFR and using low loads that normally would not cause this pain is because acidosis, as I mentioned earlier this semester, is a known noxious stimulus. Free protons, when accumulated, can trigger nociception. What this means is that with low loads with BFR, you will not be able to produce more repetitions than with the same load without BFR. And this again is due to the extreme acidosis that is caused by the imposed hypoxia from the pressure cuffs. So how do you apply BFR training/therapy? First, what cuff pressures do you apply? The recent research has shown that cuff pressures should not be generalized and must be applied in an individualized manner. At this point, the evidence-based guidelines suggest that cuff pressures should be relative to the individual's arterial occlusion pressure, or AOP. This is the pressure that is required to fully occlude the artery and thus arterial blood flow. This can be assessed by utilizing an acoustic Doppler to listen for arterial blood flow below the cuff. As the clinician increases the pressure of the cuff, the arterial flow sounds will dissipate. The pressure at which the arterial flow sounds disappear is the arterial occlusion pressure. This implies that BFR should only be applied using pneumatic pressure cuffs and not straps that are applied by quote-unquote tightening it down. You will see a lot of BFR training products out there that are simply nylon straps that you can tie around your limb and strap down. When using a product like this to apply BFR, you are essentially applying arbitrary pressures which can be ineffective or even dangerous since you do not want to completely occlude the artery. The recommended pressures for the upper body is 50% arterial occlusion pressure, and for the lower body, 80% of arterial occlusion pressure. This has shown to be optimal for restriction of arterial blood flow and occlusion of venous outflow. So with these cuff pressures, what loads would you apply? Generally speaking, anywhere from 20 to 30% 1RM all the way down to zero load have been utilized and have shown to exert some positive effects on muscle mass compared to a control condition. As far as the volume or rep ranges are concerned, there's currently debate on whether reps performed to near or complete failure is required to maximize the effects of BFR training. However, given the high metabolic stress associated with BFR, high volumes or high reps are usually unachievable due to pain, or that burning sensation, if you will. So what does the scientific literature say about BFR and its efficacy in producing hypertrophic adaptations compared to high load resistance training without BFR? Now, as you get more familiar with reading scientific studies, you will understand that the strongest evidence comes from meta-analyses. A meta-analysis is a quantitative analysis of data derived from a body of studies that examine the same thing, such as the effects of BFR training on muscle mass. Here we have a meta-analysis from 2017 on 20 separate BFR trials. Of course, since then, there has been more meta-analyses produced, and I can link you to those, but not much has changed since 2017 in terms of the consensus regarding the efficacy of BFR training. If you turn your attention to this figure here on the right, you will see a list of 20 trials, and the scale on the bottom represents the standardized magnitude of the effect of BFR training on muscle mass relative to high load resistance training without BFR. This is also referred simply as the effect size. A negative effect size represents an outcome that favors BFR low load training, while a positive effect size represents outcomes that favor high load resistance training without BFR. And of course, this is your typical means of achieving hypertrophy. When analyzing the effect sizes in culmination of all these trials, the meta-analysis showed that lighter loads with BFR produce similar hypertrophy as resistance training using heavier loads without BFR, meaning low load BFR resistance training was not superior nor inferior to high load resistance training without BFR. This would suggest that low load BFR training can be a suitable modality for muscle rehabilitation to facilitate progress towards full functional recovery. It must be noted, however, that research consistently shows that higher load resistance training without BFR induces greater strength development versus low load resistance training without BFR. This is likely due to the fact that higher loads stimulate greater neural adaptations versus low loads, and that neural adaptations are more pronounced in response to mechanical stimulation of the muscle as opposed to metabolic stimulation of the muscle. Now, another burning question we have in sports medicine is, are there effective prehab modalities for muscle strains, to prevent muscle strains, in other words? In another comprehensive meta-analysis, research examined 25 independent trials that included 26,610 subjects and 3,464 injuries were analyzed. These researchers examined studies that investigated the effects of various prehab programs on injury risk. The major programs that were assessed were stretching programs, multiple exposure training, proprioceptive training, and strength training. And the results generally showed that all exercise-based methods of prehabilitation were considerably effective for injury prevention, except stretching. Strength training reduced occurrences of sports-related injuries, including muscle strains, by about 69% and about 50% for overuse injuries. As you can see, stretching programs had no significant benefit for reducing injury risks. And this may be counterintuitive for many people, as many believe that muscle strains occur because the muscle is quote-unquote tight or rigid, like a thick and tight rubber band versus a loose rubber band. As I discussed earlier, tightness in the context of muscle physiology is not really a physical property, but rather sensory input from sensory nerves. Many believe that being more flexible is more protective of muscle injuries such as a strain, and this is simply not the case. If we remember from our first lecture, a muscle strain occurs because the MTU momentarily could not withstand a given level of tension that was rapidly applied. Flexibility has nothing to do with being able to withstand higher levels of tension. However, strength does. And this is why strength training has shown repeatedly and confirmed by meta-analyses to be the most effective prehab method for the prevention of muscle strains. In other words, high tension stress repeatedly imposed on the muscle, like through strength training, makes the muscle eventually more resilient to high tension stress and thus less susceptible to strains. Now, as I emphasized in prior lectures, a muscle strain like a hamstring strain occurs during a rapid maximum eccentric contraction, and thus it would make sense that eccentric overload strength training will be the most conducive to protecting the muscle from a strain during a rapid maximum eccentric contraction. In essence, eccentric overload exercise is specific to strain prevention. Now, hamstring strains are one of the most common among strain injuries in sports because hamstrings are exposed to two rapid maximal eccentric contraction incidences during sprinting and or running. Now, just as a reminder, these rapidly applied maximum eccentric contractions occur when there is a high external pulling force combined with a high internal shortening force or contraction force. Now, the figure on the left shows when the hamstrings are most active or tense during the sprint or running gait cycle. As you can see, it is during the initial contact with the floor and also right before the initial contact when the leg swings forward rapidly. During initial contact, which is about 0 to 20% of the gait cycle time, there is rapid braking, or in other words, rapid deceleration of the hips. To rapidly decelerate the hips, there is a rapid maximal eccentric contraction of the hamstrings, which again involves a high external pulling force and an opposing maximal contractile force. Now, right before the initial contact, which is about 70 to 100% of the gait cycle time, there is a rapid leg swing forward. During this time, there's a rapid and maximal concentric contraction of the hip flexors and quadriceps. Now, to decelerate the leg as it swings forward, the hamstrings produce a maximum eccentric contraction and thus experiences high tensile forces. So considering the fact that most sports require athletes to run or sprint, the athlete during competition will likely experience repeated and very high levels of mechanical stress/tension to the hamstrings. Therefore, hamstring strain prevention is a very important component of prehab programs in sports. Therefore, eccentric overload hamstring training is a large focus of sports medicine research. Now, in a large intervention study of soccer players by Peterson et al. In 2011, researchers compared 461 players receiving eccentric overload hamstring training to a control group who did not perform eccentric overload hamstring training. The eccentric overload exercise for the hamstring included the Nordic hamstring curl as shown in the image on the upper right-hand corner. During this exercise, the downward force exceeds the maximum force that the hamstrings can produce concentrically or isometrically, and the hamstrings therefore are forced into lengthening despite maximal effort contractions against the downward force. Now, down below on the right is a description of the intervention group's eccentric overload hamstring training program. The control group, again, did not perform this eccentric overload training. And the results were quite compelling. When looking at all injuries, new or recurrent, the intervention group has significantly less injuries than the control group. They also had a significantly lower injury rate per 100 players per season. The adjusted rate ratio, which denotes the change in injury risk, was negative 71%, which indicates that hamstring injury rate decreased by 71% with eccentric overload hamstring training as part of a comprehensive prehab program. For new injuries, the intervention group had a 59% decline in injury rate versus control, and for recurrent injuries, there was a decrease of 87% in injury rate. So as you can see, based on this large randomized controlled trial, eccentric overload training, particularly for the hamstring, is an effective hamstring strain prevention approach and thus should be included in prehabilitation programs. And as for some further evidence supporting eccentric training for hamstring strain prevention, this systematic review in 2017 showed an overall 51% decrease in hamstring injury rates when teams include eccentric overload training like Nordic hamstring curls in their prehab program. The color bars here represent outcomes for individual studies, and the white bar represents the overall risk reduction when examining all these studies together.